Hello friends, welcome to King's Cross, and today's topic of discussion is clinical anatomy of retina. Now this is a very important topic from both entrance point of view as well as for a first year postgraduate in Ophthal, because this forms the fundamental in understanding the complicated retinal lesions. So let's take it one by one. We'll start with the embryology of the eye, then we'll move to the basic anatomy of eyeball in general and the relevance with retina. So we'll discuss about the gross anatomy of retina, the microscopic anatomy of retina, and we'll end with the blood supply of retina. As an added bonus points, I will discuss about the examination aspect of retina. How do we examine retina, and what are various modalities and differences between various modalities? So we'll talk about the embryology of retina now. See, understand, retina is a piece of your brain, which means the brain is going to give retina. In fact, it is the most accessible part of your central nervous system. Like no other part of the brain which we can see directly as we can see retina. That is the significance of retina. In fact, it is the only approachable part of the brain, right? So, as I just said, retina is a piece of your brain, okay, which means the embryological structure which forms the brain should form retina. In other words, the neural tube which is formed from neuroectoderm gives the retina. So let's discuss the details further. Now this is going to be my neural tube. The neural tube is going to form three enlargements like this. Okay, the prosencephalon, the mesencephalon, and the rhombencephalon. So the prosencephalon forms the forebrain, mesencephalon forms the midbrain, rhombencephalon forms the hindbrain respectively. So this prosencephalon is going to form into two more parts, the telencephalon and the diencephalon. So this diencephalon is our concern, and this is going to form the retina, right? How? See, this is going to be my diencephalon. It is going to protrude out to form an optic vesicle. Okay, this optic vesicle is going to elongate, and here you have an optic stalk having optic vesicle. This optic vesicle is going to invaginate like this, forming so-called optic cup. Now this optic cup has two layers, an outer and an inner layer. The outer layer of this optic cup will form a retinal pigmentary epithelium. The inner part of retina forms the neurosensory retina. Let's put it again. The outer part or outer wall of the optic cup, which is thin, forms the RPE, and the inner part of the optic cup, the inner wall of the optic cup, forms the neurosensory retina. Okay, right. Now, there is going to be a potential space between this RPE and the neurosensory retina that is called as subretinal space. Okay. Yes. Now, this is going to be my optic cup with the two walls. I'm going to look the optic cup from below. So how the optic cup looks, it looks like this. So from below, I can see there is a fissure, there is a hole, and this fissure is called as the choroidal fissure, right? This choroidal fissure is also called as the fetal fissure, also called as optic fissure, is of highly significant value because this closes by 6th week of gestational age. Okay, and when there is a failure to close, it forms coloboma. It forms coloboma. So this table, choroidal fissure, close it at week 6. Okay, and when there is a failure to close because of mutations of these genes, there is coloboma. Right? Okay. Now this is a very complicated picture, but to make it very simple, you can see this is going to be the forebrain giving the optic stalk, the optic vesicle. Okay, yes. Now this optic stalk is here, the optic cup is there. There are two layers, the outer and the inner. Now as you can see a hole here. You have taken a cross section at this hole, and this is the choroidal fissure. So this fissure should close. If not, there is coloboma. So coloboma is a defect. So when there is a failure to closure of the fissure, it forms a coloboma here. You can see a keyhole defect of the iris. This is called as the iris coloboma. Similarly, there is going to be an RC coloboma, which means a retinochoroidal coloboma. Okay, so now let's go for the anatomy of the eyeball. Eyeball, in brief, there are 3 coats of eyeball. The first is going to be the outermost coat. The innermost is retina, the outermost is cornea and sclera. The middle layer is called the uveal tract or uvea, which has the iris, the ciliary body and the choroid. So these 3 form the uveal tract, and the innermost are, here comes, retina. Retina extends as the optic nerve, right? Okay. Now this retina is going to end or terminate anteriorly as ora serrata. So the anterior termination is called as ora serrata. Now retina has a small depression. That depression is called as macula. We'll discuss the details of these structures within a few minutes. So the gross anatomy of retina is this. Retina is the innermost layer. It is a thin membranous nervous layer, which means it has the nerves. Okay. In fact, it is the most developed structure. Okay. In this picture, you can understand the thickness of the retina. So the thinnest part of retina is at the fovea centralis, that is a part of the macula. It is just 0.1, not the ora serrata. Ora serrata comes second, fovea comes first, or the most thinnest. The optical disc is the thickest area. So these points are to be kept in mind. Now this is going to be the fundus, or this is going to be the retina, which I'm going to see from front. I have removed the front part, or the anterior part of the eye, and this exposes the entire retina. So this is going to be my retina. Okay. The retina is going to terminate at the ora serrata. As you can see, as the name implies, serrata, which means tooth. So it's like you have these serrations here, like this. So what lies beyond ora serrata? We have the pars plana. Right? Okay. Now, as I'm going to go in further, but before that, you can see the vortex veins here. Now, the place where the vortex veins are seen, I'm going to connect to form a circle, and that is called as the equator of retina. Okay, it's called as the equator of retina. So I'm going to zoom inside to get a piece of the posterior pole of the retina, or what we call as the fundus of retina. So fundus is just the view. Now before that, I'll just explain this important concept. Now how ora serrata gets transitioned to a non-pigmented epithelium. So iris and ciliary body have pigmented and non-pigmented epithelium. As you can see, the ora serrata will end from this picture. The ora serrata gets transitioned to a pars plana. Okay, so the ora serrata is here. This is ora serrata. This part gets slowly transitioned into the non-pigmented epithelium. The important point to understand here is this is going to be the retinal pigmentary epithelium, which I will discuss in few minutes. This retinal pigmentary epithelium is going to continue as the pigmented epithelium of ciliary body. Okay, this is the point to understand. And the basement membrane of this RP is going to continue as the Brooks membrane of choroid. Okay, just know this two points. So let us go for fundus in detail. Now this is going to be the posterior pole or the fundus of my right eye. In this picture, I'm seeing an optic disc with a physiological cup. So there is a disc and there is a cup. The dimensions is 1.5 mm is the diameter of this optic cup. Okay, it's usually pale pink in color, and there are no photoreceptors, or there are no rods or cones in this area. Thereby, we call this part as blind spot or Marriott's blind spot. The guy who found this, so Marriott's blind spot. This is about the optic disc in brief. Now let us go for the more important, our focus being macula lutea. So the name goes macula lutea. Macula means it is a patch. Lutea means yellow color. So it's an yellow colored patch. Okay. Now this macula lutea is 5.5 mm in diameter. It forms the central 15% of the visual field. Okay. Now inside this macula lutea, there is going to be fovea centralis. Now I've drawn this bigger, but in fact fovea centralis is almost same diameter of the optic disc. So fovea centralis is 1.5 mm. Now this fovea centralis is the most sensitive part of retina. Okay, and this fovea centralis has a depression or a bottom. It's called as foveola. So foveola is going to be around 0.35 mm. Okay, and this foveola has a central depression that is called as the umbo. We'll discuss the various layers of these areas later. So just know this topographical anatomy of the fundus. Okay, now let's recap. This is going to be my optic disc with a physiological cup. So outer part is called as the disc. The inner part is the cup. Okay, yes. And the structure or the nervous layer in between the cup and disc is called as neuroretinal rim. And blood vessels is going to arise here. This is called as the temporal arcade of blood vessels. So blood vessels arise like this. And here I've drawn the macula. So inside the macula you have the fovea, and inside that you have the foveola, and centrally you have the umbo, right? Okay. The area between the foveola and the fovea, between the foveola and the fovea, is called as FAZ or foveal avascular zone. Okay? Yes. These are the various important details of the topographic anatomy of retina, fundus in particular, right? Okay. Now, what is the importance of fovea? Fovea is the thinnest part of retina. As we already saw previously, the thickness of the fovea is the least here. It's almost 0.10 mm. That's the importance. Now, this is going to be my left eye fundus. So, understand always, this is the right eye. This is the left eye, which means the optic disc is always towards my nose. Optic disc is always towards my nose. This is how to identify whether it's a right eye or left eye fundus. Okay. So this picture again shows the various features of the retina. To elaborate further about the various regions of macula, which is also called as area centralis. Okay. To elaborate further about the details, here understand this is going to be the central depression umbo, fovea surrounding that, fovea surrounding that, and you have macula. Now, surrounding the fovea, you have a parafoveal area, and even surrounding you have a perifoveal area. So, this umbo, fovea, foveola, para, and perifoveal areas together constitute macula, which is 5.5 mm. Okay. Now, just to add some important clinical part about the optic disc, you can see this is going to be my optic disc. This is the normal neuroretinal rim. Now, this is going to be the disc. There you have a cup. Okay. Now, this is a normal disc. And when you have a glaucoma, what happens there? There's going to be a deep cupping because of the death of the nervous tissue. There's going to be an excavation created. And this excavation is going to manifest as a larger cup. The cup is going to be more in size. Right? So it's called as a deep cupping or a large cupping. This is an important clinical significance as far as optic disc is concerned. The details which will be discussed later in future lectures. So we come to the microscopic anatomy of retina. Now, from our school days, we would have just memorized about the anatomy of retina, the 10 layers of retina with a pain in the ass. But it is very simple. What you need to know is what are the various structures which form those 10 layers. I would say the 4 key cells with some helping cells forms the 10 layers. So what are those 4 important cells? The retinal pigmentary epithelium, the photoreceptors, rods and cones, the bipolar cells, ganglion cells. We'll take up one by one in detail. So this is going to be the eyeball. I'll draw it how I drew previously. This is going to be the cornea sclera, and this is going to be the choroid, ciliary body and iris, and this is going to be the retina. So I'm going to take a cut section like this. I'm going to put it here. So what I'm going to have at the bottom is going to be the sclera, and what is going to be above is going to be choroid. See, I've drawn the uveal tract red in color because it has the richest blood supply in the eye. Okay, this is the vascular coat. So retina here starts with RPE, retinal pigmentary epithelium. This RPE has finger-like projections or villi which hold the rods and cones, the photoreceptors, rods and cones. Okay. Now, connecting to these rods and cones is going to be a cell called as the bipolar cell. And connecting these bipolar cell is going to be the ganglion cell. And the axons of these ganglion cells, like this, all of them form the optic nerve. I hope this makes very clear, right? So 4 cells, RPE, rods and cones, bipolar cells, ganglion cells, forming the optic nerve is the final thing. So coming back, understand, here I am going to have the retinal pigmentary epithelium, rods, cones, okay? These are the bipolar cells, ganglion cells, and apart from that, there are some extra cells called amacrine cells, horizontal cells, the big Muller, the Muller cells, forming supporting role or guest role in this picture of retina. Now let's go for another picture. This picture has a more clearer understanding. This is the RPE, okay? The photoreceptors, that is the rods and cones, okay? The thin one, these are like stick rods, and the bigger stumpy cones. Now these are going to have an anastomosis, or this is going to have a plexus or a connection with the bipolar cells. These bipolar cells are going to come up, the axons of it is going to make connections with the dendrites of the ganglion cells. These ganglion cells axons are going to go back and form the optic nerve. So understand, the photoreceptor layer, okay, consists of just the bodies of the discs of the photoreceptors. I'll discuss the details just a minute. The nuclei of the rods and cones forming the outer nuclear layer, and the connections between the rods, cones, and the bipolar cells forming the outer plexiform layer. The nuclei of the bipolar cells, and not just them, as I told previously, horizontal cells, amacrine cells, supporting cells, forming the inner nuclear layer. And just above that, the plexus or connections between the bipolar cells and the ganglion cells, forming the inner plexiform layer. The neurons of the ganglion cells forming the nerve fiber layer, which in turn forms the optic nerve. So these are the layers of retina and what actually constitute them. Okay. So I've missed 2 important layers. One is the external limiting membrane, the internal limiting membrane. I'll discuss them in further slides. So we'll discuss about each layer in detail. The first layer is the retinal pigmentary epithelium. So in fact, understand there is an embryological difference between RPE and other cells, because RPE forms the first, the others form another group. Okay, so this, apart from this one layer, the other layers together constitutes the neurosensory retina. Remember, RPE is from the outer wall of the optic cup. Neurosensory retina is from the inner wall of the optic cup. Right? The first layer is the RPE. Now you have RPE, that is retinal pigmentary epithelial cells, which is going to adjacent with the Bruch's membrane of the choroid. These are the choriocapillaries in choroid. These RPEs are hexagonal cells. You look from above, you can see they are like hexagons. Okay. Now what these cells are actually placed, arranged like this linearly, and you can see some tight junctions between each epithelial cell. These tight junctions forms the outer blood retinal barrier. Blood retinal barrier is of 2 types, outer, inner. The outer is formed by the tight junctions between RPE. What about the inner? Wait till the last slide. So this is going to be the outer blood retinal barrier. As you can see, the RPE consists of melanosomes, the pigment producing melanosomes. You have the mitochondria, ribosomes, you have a cell nucleus, you have all of them, you have the microvilli, which is going to carry the rods and cones. So what are the functions of RPE? See, you can see there are going to be some tight junctions, which means that there is going to be a selective entry and exit of fluid in and out of retina. When you have a damage of RPE, there's going to be leakage of fluid either through here or here. so which can cause problems. Okay, so the functions of retina is first is the metabolism. It pumps out the fluid out of the subretinal space. So what is subretinal space? The space between this RPE and the rods and cones. You can see there is no space existing here, but actually there's a potential space, and that potential space is the subretinal space. Okay, and when there is going to be a detachment between my neurosensory retina and the RPE, this is the RPE, the subretinal space. This fluid gets collected, and there you have the so-called retinal detachment. Okay. So retinal detachment is not that entire retina gets detached. In fact, there's going to be a split in the retina. There's going to be a split between the RPE and the neurosensory retina. Right? Okay. The other important functions being the melanin granules, which gives the color to the RPE, and the important function is phagocytosis. This RPE is going to engulf the rod discs, as you can see. Slowly, RPE gets phagocytosed, or it's going to engulf this rod discs. Okay. So we come to the most important part of the retina, in fact, which is responsible for the entire vision, the rods and cones. Rods and cones are the end organs of vision. In other words, they are called as neuroepithelium. Okay, they call it as the neuroepithelium. The rods, cones, what is the ratio? There are 120 million rods, 6.5 million cones. So the ratio is almost 20:1, right? The ratio between rods and cones is 20:1. Now these are the photoreceptors, because they're going to receive light and they're going to convert the incoming light energy into a chemical energy, which in turn converts into an electrical energy as optic nerve. Okay. Now, just know the important points here. Rods and cones, I'll discuss the structure, I'll come back to it now. See, the rods and cones have very important structure details. There is going to be two important parts to understand. The first is going to be the outer segment. This is the outer segment. Okay, and you have an inner segment, and this is going to be my inner segment. Then you have an outer rod fiber, inner rod fiber. Okay, understand again. Outer segment, outer rod fiber, inner rod fiber. Easy. This outer segment has these discs, or called lamellar discs, which contain the visual pigments. So the visual pigment of rods, the rod discs contain rhodopsin. Cone discs contain iodopsin. Okay. The rods, okay, this is the inner segment, and this junction is called as the IS-OS junction, which is a very important landmark in the OCT, or the scan what we do to understand the layers of retina in certain disease conditions. So first we have this, the outer segment, the inner segment. The inner segment of the cone has two parts. One is the myoid, the other is ellipsoid. Same can be applied for rods, but we commonly use this term for cones, the myoid, ellipsoid. Okay, the ellipsoid contains the mitochondria. The myoid contains the Golgi apparatus. Okay. Then you have the nucleus, and you have the inner fibers of rods and cones, and they're going to end up into a synaptic terminals. We give the name spherule for rods, and we give the name pedicles for cones. This is the most important part to understand here. Okay. Now, an important clinical significance is, you take the fundus. The centrally you have lots of cones, and peripherally you have rods. What is the significance of it? As you might recollect, cones are essential for color vision. Cones are essential for color vision. Not just that, they are essential for form sense or to discriminate the shapes of the objects. Cones are essential to see in light, the light vision. So accordingly, during light, my pupil is going to constrict. So what happens? Only this part of the retina gets exposed because the pupil constricts. So cones are exposed. So naturally, cones have the visual acuity is maximum at this area. So which really helps us to see during day vision. Whereas during night, our pupils dilate, exposing rods. So thereby, which is essential for dim vision. So rods is going to be for dim light. Cones are going to be for bright light. Okay. So, with these important differences, I end the discussion on rods and cones for now, and I'll go to the next important cell, that is the bipolar cells. Now, bipolar cells are the first order neurons of the visual pathway. According to Parsons, and not according to other books, Parsons says that the first order neurons are bipolar cells. The second order are ganglion cells. And the third layer or third order is going to be the lateral geniculate body. A very, very important MCQ. But there is a controversy. Books on retina and retinal anatomy says that bipolar cells are the second order neurons. So there is always a confusion between which is the second order neurons. These books say bipolar cells is going to be the second order and ganglion cell is the third order. Okay? But for all practical purposes, as far as your MCQs are concerned, it is always good to stick with Parsons and the first order neuron will be bipolar cells. But for those who are first year MS or the Ophthal PGs, I think it's always good to quote some standard textbooks like Ryan Retina and Wolf's Anatomy, these books saying bipolar cells are the second order neurons. So here is a controversy and hope this helps. Now, bipolar cells, as the name goes, has two poles. So if you have a nucleus, there is one pole, there is another pole. Okay? So an important functional significance with the bipolar cells is that, see, in other conditions, to excite a cell, there is going to be a depolarization. Usually, when there is going to be a depolarization, it is going to excite the cell, activate the cell. But here, as far as your photoreceptors as well as your bipolar cells are concerned, hyperpolarization will switch on or will excite the bipolar cells. There is even more details with this, but to understand this is very, very important. Okay? So moving on to the next cell, there is ganglion cells. Ganglion cells are the projection neurons of retina. They are the projection neurons of retina. Okay? These ganglion cells are having two parts. You have the dendrites, which are going to synapse with the axons of the bipolar cells. Just draw with a different color, okay? This is the bipolar cell, this is the ganglion cell. The axons of the ganglion cells forms the nerve fibers of the optic nerve. And there are 1 million ganglion cells compared to 125 million rods and cones. So what this shows is that there are too many photoreceptors, but too less ganglion cells which are actually forming the optic nerve. But this is at the outer part of retina. But at the center part of retina or the macular region, there is an 1:1 ratio or a connection between ganglion cell and the photoreceptors, cones to be more precise. Thereby, it maintains more importantly, increased visual acuity is maintained. Okay. Some more details about ganglion cells. There are two types of cells, M cells and P cells. P cells stand for midget ganglion cells because they'll be small in color, small in shape. M cells form the larger cells. Very important point. P cells are color sensitive. M cells are motion related. So P for color, M for motion. Understand? Okay. So what is the significance of this? Retina has these two cells, the midge cells, which are P cells. These parasol cells are so-called the M cells. This M cells is going to form the magnocellular pathway. P cells forms the parvocellular pathway in the lateral geniculate body. So as I said, these parvo cells are important in color. Magno cells are important in motion. Two important MCQs. Now we'll go for the supportive cells. So we've discussed so far RPE, rods and cones, the bipolar cells, the ganglion cells. And now we'll discuss the supporting role played by these cells. How to remember them? High man. Okay. So horizontal cells, amacrine cells, interplexiform cells, Muller's, astrocytes, and microglia. We'll take them one by one. Horizontal cells. Horizontal signal transmission from the rods and cones to the bipolar cells. So here you have the rods and cones to the bipolar cells. The horizontal cell is going to have a connection between them. So they will enhance the visual contrast by lateral inhibition, which means they will provide some, they filter out the unnecessary noise and give the important visual contrast. This is the role of horizontal cells. Whereas the amacrine cells is going to be above. They're going to synapse with the ganglion cells as well as the bipolar cells, and they provide negative feedback. So horizontal cells, lateral inhibition, amacrine cells, negative feedback. Now moving on to Muller cells. Very important and interesting part of Muller cells. Muller cells forms the backbone of the retinal structure. Okay. Now you can see Muller cell is in fact a very large cell. It's extending. It just almost entirely compasses the entire length of the retina. Okay. So you can see the Muller cell extending almost up to the cones and rods and extending up to the inner limit of the retina. This Muller cell is going to give these two projections here, and it forms the outer limiting membrane and the inner limiting membrane. Just understand that. So outer limiting membrane is going to be the junction between the nucleus and the body of the rods and cones here. Okay, that is going to be where the external limiting membrane or the outer limiting membrane is going to be. The inner limiting membrane is just inner to the nervous or the nerve fiber layer. So Muller cell is important in that it is going to form the backbone. So what about the other cells? See, interplexiform cells connects the two plexiform layers. So this is the interplexiform neuron connecting the outer and the inner plexiform layers. What about astrocytes and microglia? Now these are the other glial cells. So this Muller cells, astrocytes, microglia, these are all the glial cells which will provide the support to the retina. So with these details, let's put them all together. So with the 10 layers, RPE, the photoreceptor layers of rods and cones, the external limiting membrane, the outer nuclear layer compassing the nuclei of the rods and cones, the outer plexiform layer where the rods and cones talk with the bipolar cells, the inner nuclear layer consisting of the nuclei of not just bipolar cells but also horizontal cells and amacrine cells as well as Muller cells, the inner plexiform layer where the bipolar cells talk with the ganglion cells, and the nerve fiber layer, which is nothing but the axons of the ganglion cells and the interlimiting membrane. So 4, 5, 6, 7, 8. 4, 5, 6, 7, 8, 9. Okay, here I have missed 5. Okay, 5, 6, 7, 8, 9, 10. So 10 layers, okay? That's it. Okay, we have come to the fag end of our discussion here. So the retinal layers at macula, very important point. What happens in macula? As you know, macula is the central part of the retina, and you don't see all the layers as you might expect to see in the periphery of retina. So macula, important points to understand is that at macula, the ganglion cells are heaped up. The ganglion cells, okay, the ganglion cells kind of heaped up. There will be more than one layer of ganglion cells. Whereas at the fovea, there are no rods. Not just at fovea, even at foveola, even at umbo, there are no rods. They have maximum concentration of cones. So there's cones and only cones there. The cones are abundantly, tightly packed cones. The outer nucleus, here you can see the large number of cones, tightly packed cones are to be seen. Okay, the outer plexiform layer goes like this, goes radially and peripherally, forms a layer so called the Henle's layer. Very important. Henle's layer is nothing but the outer plexiform layer at macula. To be more precise, at fovea. What happens at foveola? Vision is most accurate at foveola. There are almost no ganglion cells at foveola. You can see the ganglion cells are not seen. Okay, this is in fact the thinnest part of retina. To add more details to it, look at the histological section. As you can see again, this is going to be the Henle's layer, the outer plexiform layer. Okay, this is the outer nuclear layer with more concentration of cones at the center. And you can see there's almost no ganglion cells. You can see ganglion cells here, but as you come to the fovea, there is very minimal ganglion cells. Okay, yes. And the nerve fiber layer is going like this. Now, some important points to understand. I said cones are concentrated more at the center. Okay, so it's like a cones getting sandwiched between, okay, the cone nuclei getting sandwiched between the other parts of the cone, the body of the cone, okay, and the Henle's fibers, kind of getting sandwiched between them. So it's called as a cake. It's called as a nuclear cake. The other name for this nuclear cake is GATEAU, gatu nuclear. Gatu nuclear is the other name given for the nuclear cake, which is nothing but the cones getting sandwiched between them. And one important point to understand here is this: the umbo. The umbo is also called as the central bouquet of cones. The central bouquet of cones. And foveola is called as the bottom or tip of fovea. Okay. So with these points, I would like to go to the blood supply of retina. Very easy. Blood supply of retina, you see we have 10 layers of retina. So I'm going to split into outer 4 layers and inner 6 layers. The outer 4 layers, which are adjacent to choroid, is going to be supplied obviously by the choriocapillaries derived from the ciliary vessels. The inner 6 layers are going to be supplied by the central retinal artery, which is the first branch of the ophthalmic division of internal carotid artery. Okay. Now, a very important point to understand. As I discussed previously, I told what is the outer blood retinal barrier. Okay, that is the junctions between the RPE cells that form the outer blood retinal barrier. Okay, what about the inner blood retinal barrier? It is formed by the tight junctions between the endothelial cells and also the Muller cells and also the pericytes covering this endothelium. So this is going to be a tight junction which is going to prevent a barrier, which is going to form a barrier which will limit the movement of the fluids, electrolytes and other substances in and out of the retinal capillary cells. So the inner blood retinal barrier is vascular. It is vascular. The outer blood retinal barrier is epithelial. Important point. So what are other blood-retinal barriers? You have the blood aqueous barrier. So there are two barriers in eye: blood aqueous barrier, blood retinal barrier. Okay. Important differences between retinal and choroidal circulation. As I already mentioned, the inner 6 layers supplied by the central retinal artery, and the outer 4 layers with the choroid supplied by the ciliary arteries. Choroidal circulation is the highest in the body. I've discussed this previously. In fact, the uveal tract has the maximum blood supply. Okay? Yes. The cellular junctions between the retinal endothelial cells, where they're going to have some tight junctions which forms the inner blood retinal barrier. Whereas for choroidal circulation, there is going to be fenestrations in the choroid capillaries. Retinal arteries are end arteries. There are no anastomosis. But whereas choroidal arteries are functionally end arteries, but they're anatomically not. They have choroid capillaries there. So, how the retinal circulation is going to be regulated? There's going to be auto-regulation of retinal circulation, whereas autonomic nervous system regulation choroidal circulation. So now, we will talk about the examination of retina. Now, how do we examine retina? There are different ways to examine. Okay, this is one of the way where this doctor is going to use a handheld direct ophthalmoscope to see the fundus of the retina of this patient. The other way which he can use is going to be by using an indirect ophthalmoscope, an IDO, indirect ophthalmoscope. Okay, this is the second way. Third way, he can use a slit lamp with a condensing lens. So understand, he does not use any condensing lens or any extra lenses to focus the light on the retina. But when he's going to use an indirect ophthalmoscope, when he's going to use a slit lamp, he uses a lens. So the differences between direct and indirect ophthalmoscope is an important MCQ. Do we use any condensing lens here? No, we don't. But we use, and the lens commonly used is 20 diopter lens in indirect ophthalmoscope. And what about the image in direct ophthalmoscope? It is going to be virtual and erect. For instance, if I'm going to see the right eye, I will see image as in the right eye. Just like that. Okay. So nasally I will be seeing the optic disc. Temporally I will be seeing the macula. But in indirect ophthalmoscope, it is just inverted. And not just indirect ophthalmoscope, as well as in slit lamp examination, it's going to be inverted. So I'm seeing the right eye. I will look at the inverted image like this. It's real inverted. Okay. With DO, the examination is not possible through hazy media or a very dense or opacified media, but it is possible with indirect ophthalmoscope. DO has large magnification. I can see a large area that is 15x. It's highly magnified, whereas indirect ophthalmoscope is not that magnified. But the good thing about indirect ophthalmoscope is that though the magnification is less, I can see the entire retina, that is up to ora serrata and even more than that. I can see in indirect ophthalmoscope. But in case of direct ophthalmoscope, I can see only the fundus, macula up to equator only. This forms the important point. Differences between these two devices. Finally, I will end with this. Okay. Now you saw rods and cones, you saw bipolar cells, you saw RPE before that. Now based on these structures, there is one important application, that is electroretinogram, which is nothing but the recording of the electrical activity of the retina. So the receptors and the bipolar cells are the key features here. There are 3 waves: A wave, B wave, C wave. From this picture, there is A wave, B wave, this could be the C wave. A wave and C wave are dips, which means they are negative waves. B wave is a positive wave. Okay. A waves arise from the photoreceptors, rods and cones. B wave arise from bipolar cells, B for B. C wave arises from RPE, also from rods and cones. So important MCQ points are: A wave from receptors, B wave from bipolar cells. questions. And that ends this discussion on retina. Now, this lecture is primarily intended, as I'm going to reiterate again, is for the pre PG as well as the first year PG. So, hope I have fulfilled the requirements of you too. And thanks a lot. It's been a long time since I have recorded this video, and I'll be happy to share even more. Put in your feedback. Happy learning. Thank you so much.